Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, how are you? Glad to have you here. In that you can hear me right now, that means you've made a pretty wise decision. I'm going to fill you up with a bunch of information in this program. Dr. Randall Juliff from the Vein Clinics of Hawaii in the studio with us on a show that we're doing weekly, and it's actually pretty much run the gamut of everything to do with your circulation, your circulatory system, particularly your legs. And today, typically, we're going to talk about other case studies. You can go to veinclinicsofhawaii.com anytime and see the depth and the scope of the services and treatments offered by Doc and by his staff on all the islands. Actually, Big Island, Maui, and here on Oahu. And it is because of the case studies that we're able to do, everybody fits in. And I took a look at this one that Doc sent me the other day. Is this me? No, but it's pretty close to me. Not only do I host the show, but I'm a patient going through some really interesting experiences in the modern way of treating venous disease. So that's a heck of a long introduction, but here you are again. Good, nice to see you, Doc. It's true. When we first started doing the show, obviously there's several areas in which you treat, but it seems to me that this one, DVT, because you see it a lot on television at night. They'd say, DVT sufferers. Are we becoming more, what exactly is DVT anyway?
Well, DVT, that stands for deep venous thrombosis, and most people understand that as being a blood clot, which it is. And blood clots can arise in the venous system. Typically they arise in the deep veins of our legs. And those are the big ones, the ones that are carrying the most blood. And they arise from a variety of different reasons. Usually it happens in a scenario where the patient or the person is immobile for a while. DVT for a long, long time was a tremendous problem in hospitals. And until we started doing prophylactic therapy for it, so that people didn't develop DVT. But people are sick, they come into the hospital. We throw them into a bed, and then we start to treat them. So not only are they immobilized, but they also have health issues going on, and so they're set up. We've talked about people being on airplanes. Yeah,
traveling is a big deal now, particularly as we age, right? And we're finally able to start clicking things off the bucket list, but they all involve 5 or 6 hour plane rides.
Right. Yeah, especially for people who live here in Hawaii.
Yeah.
It's sort of a mandatory immobilization, and they don't encourage you to get up and walk around much anymore on airplanes.
Yeah. As a matter of fact, that's really true. Ever since 9/11 and just terrorism in general, our lives have been changed forever. And it used to be you were waiting for the captain's voice. Hey, folks, feel free to wander about the cabin. You don't hear that anymore.
No.
You hear, sit down, wear this belt.
Yeah.
But that does put us at risk. You've explained some things we can do. Maybe given time later on in the program, we can tell people that have to go on these long flights what they can do to sort of mitigate that immobility for a while.
Sure.
Okay, so true, right? As we age, these things, and it's actually some of the things that I see on TV that you can talk about. It's scary. Because they scare you, and what the consequences of these, if they go untreated, what they can do to you.
Yeah, and I think sometimes I think especially the media and television, they scare people needlessly. But for DVT, I think it actually has been a very good thing. Because people have to be educated in various things that you can do to limit your risk. And especially because of the fact that DVT has so many negative repercussions over a long period of time, including death. There's a whole bunch of people that die from, DVT / pulmonary embolism, which is, the clot breaks off and goes to the lungs and can be a very fatal situation. And, there's a good number of people in this country that die from that every day.
And, the other side of the coin here, gang, we talk about how the risk factors are increased by folks living here in Hawaii because we have so far to go each time. But the opposite is also true, isn't it? That there's a lot of people that come here from other places, and they come here to enjoy themselves, and they find out that their legs all swelled up or they're in pain. And I understand our trauma centers and our emergency rooms here in Hawaii get a lot of tourists, that have this condition.
Right. Yeah, and we see some of those people, especially, local people who are flying back, and, they get off the plane, and all of a sudden they start having symptoms. They go to the ER. They say, yeah, you have a DVT. They start to treat it, and then we serve sort of as the follow-up.
Yeah, I was going to say, when you say they treat it, what is the treatment for DVT?
Well, they basically it's anticoagulation. We need to thin the blood, and we're going to talk about that a little later. But so we thin the blood, and but that patient needs follow-up, and actually, this patient sort of epitomizes a scenario where, this guy, he didn't have appropriate follow-up. As a matter of fact, he didn't even know he had a DVT.
Yeah, that's the other big concern.
And so it can lead to, real, like I said, negative repercussions, which are some of the things that he had.
Okay, so what we're talking about here, gang, and we love doing this is an actual case study. This is a 77-year-old male. And, you can say, well, I'm not 77. Well, listen, you don't have to be 77. But this is the area, all of us that are getting a little gray on top, this is the area where you really have to pay attention. So this guy's 77. So a lot of people in this audience are going to relate to that.
Sure. But you're right. I mean, you don't have to be 77 to develop a DVT. I mean, it's we see that in any age. Yeah. But anyway, this patient is 77. And, for 77, he's a relatively healthy guy. He's got high blood pressure. He's being treated for cholesterol. He had a history of stroke. Now, stroke is primarily an arterial problem. It's not a vein problem. But it was kind of a minor stroke. He got over it. There were no really long-standing repercussions of a stroke. So he was an active guy, and I think, as I recall, he was even working part-time in the kind of work that he had done previously. A relatively healthy, active 77-year-old. But
what I read about him also, Doc, is that at 77, he started developing or displaying the typical things that start happening to you, which is, in his case, I guess, was other concerns. You said the history of stroke. But what about the complication of just aging and still trying to do things and forcing yourself to do things that are maybe harmful?
Yeah, I discourage that concept in most of the time because I think the general tendency and the advice that people often get.
Oh, slow down. Why?
Exactly.
Don't slow down.
I think that if you're capable and if you're not going to do any harm, which, activity rarely does, I mean, unless you go to the extremes, staying as active as you possibly can throughout your life, I think, is a tremendous benefit. And I've only seen good things, for the most part, come from that.
Maybe you could explain what happened to this guy by some of the symptoms that he started displaying and living with. Yeah.
So over the prior several years before he came in to see us, he started having symptoms of achiness, heaviness, muscle cramping, and swelling. Well, those are the very, very most common symptoms that go along with venous insufficiency and venous disease. And he had a fair amount of swelling, which was a fair bit more worse on the right. So one leg had a lot of swelling. The other leg had a little bit of swelling, not so much, both legs had symptoms. The right leg, which was the more swollen one, had a few more symptoms. I think.
Is that typical? I know in my case, it is one leg is a little bit worse than the other.
Yeah. That's pretty common in any situation. Sometimes we get a little more concerned if there's a lot more symptoms on one side or the other, and we'll get into that in just a bit. So, in examining the patient, we, obviously we look at the legs, and we saw that he had pigmentation of the skin, which is another very common symptom of venous insufficiency.
Yeah, you start seeing that first, the splotchiness, and then it changes. It actually starts to look like, am I sunburned here? Or,
right.
What's happening here?
Yeah, and a lot of people confuse that. A lot of people see that coming on, and when they do come into the office, at some point, then they say, well, gee, I thought it was just, I've been out in the sun all my life, and but when you see that darkening of the skin, that dark pigmentation that typically starts about halfway up your calf, and then it gets worse as it goes down. That's more than just being out in the sun. But so he had mild pigmentation on the left. On the right, he had very marked pigmentation, and it was also starting to develop, what we refer to in a general sense as skin changes. He had thickening of the skin. The skin was becoming dry and scaly, has a rashy kind of appearance to it. Something that we call venous eczema. Yeah,
let me ask you this, because I've experienced this, and, some of you should know by now, not only am I the host of the show with Dr. Gillett, but I'm a patient. And I've been really learning a lot about this show and about being a patient. And I can tell you that you learn as a young person that your skin is an organ that replaces itself all the time. Well, obviously, once you get into this pigmentation and that other stuff, it's not being replaced. It's just staying there, and it's getting older, and it's leathery.
It is, and it's not that it hasn't stopped replacing itself. It probably, the cells are still being replaced. It's just that the abnormal function and the bad things that happen because of vein disease and what we call venous hypertension and its effect on skin, if that's not relieved, then those skin changes just continue to get worse and worse. Now, when we fix people, when we fix their vein function and we do the other things that need to be done to control that swelling and control the venous insufficiency, some of those changes will get better. Now,
I'll agree. That's happened to me. Now, I was disappointed in the very beginning to learn that there wasn't going to be much that can be done for going back to whatever normal is.
Right.
But that you can curtail and end the deterioration by treatment.
Yes.
So you just get to a point where, well, it's ugly, but it's not as ugly as it could be.
Yeah. Well, and more importantly, the process isn't continuing.
Exactly.
So that it doesn't get worse.
Or worsening,
But and typically the pigmentation, unfortunately, because most people focus on pigmentation, they don't want that, dark staining of the skin. Unfortunately, the staining usually does not get a lot better, but that thickening, that fibrotic kind of feeling to the skin, over a period of time, it sure doesn't happen overnight, but after we treat people over time, it does start to soften up a little bit.
Isn't it sort of amazing? And I've noticed it since we've been doing the show, that there's more and more different kinds of makeup and cover-up being made available to things, not just a little rouge for the cheeks. I mean, you can go down there on the legs and cover up that stuff.
Well, a lot of our patients, do that, and they come in saying that, they're getting tired of having to put makeup on their legs all the time, so that's what kind of brought them in. But there's a lot out there if you need to, but this guy had more problems than what makeup was.
He was not worried about the looks; he was worried about the function.
Yeah. So he had not had an ulcer. Ulcer was kind of the next step for him. That's how much the right leg had progressed. So we talk and we've talked before about the classification of venous disease. He would be a what we would call a four class.
Out of six, my friends.
Yeah,
six.
Yeah, 4 out of
he'd
6.
Be a 4. Yeah.
More precisely, C4B. And so he's got major problems. So what do we think? Getting back to the issue with this patient, that he had one leg that was quite a bit worse than the other. Now, can that happen in just a typical kind of setting of underlying venous insufficiency? Yeah, we see that sometimes, but when it's so marked, we have to think about other things. What else is going on? Is there something else going on additionally in this patient's right leg that has caused it to progress to the point that it is right now, as opposed to the left leg?
Okay.
So anyway, so we go looking, and we, what are some of the things that might do that, especially as it pertains to, swelling, and there's this issue of the lymphatic system, and we've talked about that a little bit. Lymphatic flow has to do with, just clear fluid in our body moving from one place to another, and that gets particularly important with our extremities. And, fluid gets filtered through lymph nodes, and, that's all part of it, too. So,
by the way, somebody heard us talking about that and asked me when I bumped into him, what is the lymph system, the lymphatic system? What is its contribution? We know what the circulatory system is. The veins and arteries take the blood and do this. What does the lymph system do?
Well, the lymph system is, specifically has to do with the movement of clear fluid, plasma, non-blood kind of fluid that, 70% of our body is water,
Yeah, so you're talking about this is for lubrication, this liquid. What is its purpose?
Well, it's, there's again, 70% of our body is made up of water. So there is water in cells.
Sure.
There's water around cells. There's water in, what we call interstitial tissues. And there's sort of an ebb and flow of that water. It's not like it stays stagnant in any one place. And again, especially as it pertains to our extremities, that fluid has to have, it's got an ingress, egress, and
so this is the system that moves the liquid around for where it's needed or where it's not needed.
Yeah. And sometimes, those tiny little lymphatic channels are carrying a fair amount of fluid, on an hourly basis, quite frankly.
I mean, would someone think that that's where the quote, water on the knee comes from?
Probably no. That's more of a joint problem.
Okay,
that's more of a joint problem, not necessarily lymphatic. So what do we call that? Well, we call that lymphedema, and so we get one of the things that can cause swelling is lymphedema. Typically, or probably more commonly, we see lymphedema in both legs. Sometimes it can be in only one if that one leg has been affected in some way. For instance, if the patient has had prior surgery, whenever we operate on somebody, we're disrupting the lymphatic system to one extent or another, and that in and of itself can create swelling over a long period of time. If somebody has had radiation therapy, for cancer, that also can affect lymphatic flow. So any of those things might lead to more swelling on one side than the other. He didn't look like that. He didn't look like lymphedema in one leg and not the other.
By the way, it's pretty interesting because what I'm gathering from this is that when there is a marked difference between the two legs, there sort of a red flag's got to go up.
Exactly.
Because this swollen leg needs to be treated, because otherwise it would be like this leg, which is not as swollen.
Right. Yeah. Frankly, in this patient, he's got venous disease. So in his left leg, which is the one that's not as swollen, he has signs of venous insufficiency in that leg also. It just, it appears that there's something more than just, routine venous insufficiency going on in his right leg. So, lymphedema is one of those things that might cause unilateral swelling. Another one is DVT, as we've talked about. If somebody forms a blood clot, especially if it's higher up in the leg or in the pelvis. Sometimes we don't see it in our routine ultrasounds, but we always have to consider DVT. There would be the potential of a mass in the pelvis, for instance, and sometimes we have to do CT scans and things like that to rule out, again, an obstructive kind of process going on that's causing one leg to swell more than the other.
Isn't it interesting when that happens, when it comes on slowly to a person, that they don't really know it? And you told us before that some of these masses can get pretty big. Mm-hmm. I mean, they can get in there and say, how in the heck did somebody not see this coming or feel it?
Yeah, sure. Yeah. Absolutely. So, and then there's some other unusual things, something called, there's something that we've talked about before, May-Thurner syndrome, and that has to do with an artery in the pelvis compressing a major vein in the pelvis, and that can cause what we call unilateral swelling, swelling in just one leg. And, we always think about that when we're searching for a reason for it. May-Thurner is something that happens more to the left leg rather than the right. So, again, that was not his particular picture. So we, like we've talked about, we start out with an ultrasound of the legs to kind of start, figuring out what's going on. And in him, we found out that he had evidence of having had a prior DVT, deep venous thrombosis.
Can somebody have one of these things that semi-self-clears itself and, doesn't have any symptom? And isn't it true that sometimes when you finally get to look at a patient like me or like somebody else, you can say, there's evidence of this happening. This is not a new thing. It's been going on. So in some respects, I guess your body does work on getting rid of it. But then there's some that are just too big and that need help.
Exactly.
Need treatment.
Yeah, you're absolutely right. I think DVT, the extensiveness of any one DVT that somebody has developed, there's a huge spectrum. Mm-hmm. Like we've talked about, some the veins in our upper leg and especially the ones in the pelvis, those veins are big. Mm-hmm. And if they get, if a blood clot forms that completely occludes those veins, that's a pretty big blood clot.
That's a big issue, big problem.
Now, on the other hand, if somebody develops a vein in the lower part of the leg where the veins are not quite as big, that's fairly small. Much less likely to develop major symptoms, and the body can resolve those clots, process the clot, and often we don't even see evidence of that in the future. So that kind of thing happens for sure. We found in him evidence of DVT, but in the location of the DVT was in the mid part of his right thigh,
which is pretty high up, right?
It's relatively high. Yeah. I mean, it's not as high or as extensive as having a pelvic DVT, but still it's pretty what we call proximal DVT, and can have major repercussions as we are going to find in this patient. Now, so basically that that answered our question as to why did this guy have so much swelling on one leg and not the other. We don't typically look otherwise in that kind of situation once we find the reason. If he had not had that DVT, then we would have probably been looking, further up in the pelvis and abdomen with CT scan and all that sort of stuff. So, now the thing with him, however, is that that vein, we call that the femoral vein. That vein was completely occluded. There was no flow whatsoever.
Yes, in other words, nothing's happening there. It's like it's poor old salmon swimming upstream and there being no water.
Exactly.
Yeah, terrible.
So, and typically, when we know about a DVT and we treat a DVT, the body is able to, like we talked about, process, break down to some extent that blood clot, at least to reestablish some amount of flow. So that absolutely does happen. Your question before was a good question.
Okay, and by the way, gang, speaking about questions, whenever you've got one or a concern, you should go to the website. It's been constantly tweaked on, and we're really proud of the way you can get a bunch more information. Go to veinclinicsofhawaii.com, veinclinicsofhawaii.com. Find out more about it. It's easy to do, and even if you just Google, venous disease or vein clinics Hawaii, it's gonna you'll hit right on the website. There's a myriad, just a wealth of information there.
Mm-hmm. Yeah. And as a matter of fact, there are these recordings.
Yeah.
So if you've missed prior radio shows, they're all there for your enjoyment.
In perpetuity.
Yeah.
We hope, yeah, it's out there.
So the ultrasound showed that the femoral vein was occluded completely. There was no flow, but there was a prominent, what we call collateral flow. Mm-hmm. Now, what is collateral flow? Well, collateral flow is that luckily our body accommodates for bad things, and when somebody develops a DVT like this that completely occludes the main avenue, then our body develops little roads kind of around the main, roadblocks. So it's like, the H3 has closed down completely, and but you get off the highway,
right,
you go through the side streets. That's collateral flow. Yeah. So, and we can see that on the ultrasound. Mm-hmm. Now, what does that mean? Well, that means that again, there is little to no flow through the main vein, and also more importantly, because this sort of impacts our decision making with respect to treatment, is that chances are this happened quite a while ago, because it takes a while for those collateral channels to develop, especially to develop into the size that we can actually see them on the ultrasound.
By the way, speaking of ultrasound, I've had some recently, and it's, I think, and I know you heard this from everybody else, but when I was doing it with Michael at your office a couple of weeks back, you feel like you're being much more part of knowing what's going on when you say, those are my veins, and that's my circulation going. You can actually see your body. You look at the screen and think, holy smokes. And it'll say, you see that? That's a this and that. Really? How are we gonna? That's got to go, right? Yes, that's got to go.
Yeah.
It's very. Yeah. I don't want to say it's fun, but it's very educating.
Yeah. Well, and it is
fun.
It brings it all home, because you're looking at your leg and you're saying, gee, why is this happening? Yeah. And then when you can look at an ultrasound and actually see why it's happening, it all makes sense.
Here's the part that I get really impassioned about, and that is the deterioration or change between visits. And that's why once you get on sort of like I am on a maintenance program, I'm having some pretty serious work done right now, but I can tell you that when you can see it and it's recorded, and then you go back in for another ultrasound checkup, later on, if you've had a procedure, there is a marked improvement in the circulation in that leg that just would not have been possible without treatment.
Yeah. Sure.
That's really good fun. That's the fun part.
Yeah. So anyway, so these collateral channels become important, because now they are, the blood has rerouted, it's going around the major roadblock, but still it's not functioning those collateral veins are not functioning anywhere near as competently as the main, highway. So therein is the reason why this guy has developed more swelling and more skin changes, more advanced
in that leg
symptoms. So otherwise, what did we see on that ultrasound? Well, we've been talking about the deep venous system, the deep veins. Well, he also had superficial reflux, and he had superficial reflux in both his greater saphenous vein and his small saphenous vein, two veins that we work on all the time. And in addition, he had reflux in a very prominent accessory vein. And this is a vein that we call the posterior accessory vein. It runs up and down the back of the thigh. And we did see some reflux in that vein also. So the question is, so what do we need to do to try to begin to fix things for him? And we'll go through that in a bit. But getting back to this blood clot, after we found the fact that he had a blood clot, we went obviously back to the patient and we said, hey, did you have a history of DVT that you didn't tell us about? And he said, no, I don't have any history of DVT. And I said, has anybody ever put you on a blood thinner for any reason whatsoever? And the answer to that also was no. So this doesn't happen very often, but every now and then we'll run into somebody who had a blood clot, has findings on the ultrasound that there was a DVT in whatever location at some point in the past, and we can tell when it looks like old clot versus a new clot. And it's not uncommon every now and then for you to see kind of remnants of clot after, somebody's developed a blood clot and their body has resolved, on its own, that blood clot, and there's just a few little remnants, and hopefully there isn't too much functional deficit from that, but we do see that. For him, having had a blood clot in the location that he did, it's unusual.
I was going to ask you about that.
Yeah, that he would not have had any symptoms that would have led him to, look into this at some point in the past, and unfortunately didn't have the benefit of being put on anticoagulation, because that's probably why his, the whole process developed in the way that it did, that vein not reopening to any extent, and him having just collateral flow through that part of his leg and the additional problems that he's developed.
Okay, and here's the part where I think it's very interesting to me, because I think all of us are way more aware of some of these medications that we're talking about, because of we're just getting bombed with them every day, every night on television, and we never really talked about this before. But I'm on one of these blood thinners through Dr. Juleff, and by the way, this is something that's very interesting, not only as medical director, but looking at why you take these things. What's the good, the bad, and the ugly is what I've learned is what is this supposed to be accomplishing, this blood thinner, and what do you have to be careful about? I mean, obviously, if you got thinner blood, that means, you're not clotting as quickly as or coagulating as quickly as you should. But I think what people need to remember is when they hear this thing about a blood clot, they mistake a blood clot for a little thing on their wrist or on their arm. Yeah. When you're talking about in the venous system, these blood clots can be very long, and if they break loose or parts of it break loose, it's like a wrecking ball going through your body.
Yeah. Yeah, getting back to what we were mentioning before, especially if in the higher veins, the veins in the upper leg and pelvis, those blood clots can be large, and when they break loose, they follow the venous system up through the body, and they track, they go through the heart. They don't really have any major effect on the heart usually, but they go to the lungs, and that's how people die from pulmonary embolism.
But that's why I'm saying that some of the ads, and I want to get back to that, that you see on television at night, thank goodness in many respects. I don't know why they feel compelled to advertise that stuff as much as they do, but probably because it's the new darling of the medical world, right? I mean, and so one would think of, can you make your blood too thin? And the answer is yes. You have to be really monitored taking this stuff, don't you?
Yeah, you can. I think the reason that you're seeing more, advertising with respect to blood thinners is that just over the past,
we're getting older.
That too, but just over the past 10, 15, the gold standard for blood thinning in the past was warfarin.
Yeah, warfarin, whether they call it heparin or Coumadin or whatever.
Well, heparin is something different.
Oh, okay. That's right.
But Coumadin and warfarin are the same. And we used that exclusively for many, many years. But it's just been over the past 10 or 15 years where we have had new choices in blood thinners, similar to the type that you're on.
Yeah, they even make songs of the darn thing,
They make it almost sound fun.
Yeah.
And so I think there's just been, a marketing blitz because of these new blood thinners. And there are, strict advantages to using these newer blood thinners as opposed to warfarin.
Let me tell you how true that is. And hearing Dr. Juleff talking about it is one thing. But I'm a patient that's doing it, and that's another. And when you have if you've had, say, a blood pressure of this over this for such a long time, and then you start taking some medicine that works on things, and one of the side benefits is, wow, my blood pressure is going down, or wow, it's going up, wow, it can be regulated. it really does put a different spin on how you feel about taking this stuff, because you got to weigh it, right? I mean, some of it's risky. They tell you of all of the things
Sure.
it can be, and you as the physician, when you assign that to me, it was with knowing, all right, you really have to watch when you first start taking this stuff if there's any changes. Mm-hmm. And there was, one day if I had a nosebleed, I didn't expect it, but after that,
Yeah.
I mean, whatever risks that stuff has for me, the benefits far outweigh them, I think.
Well, and that's just it.
Yeah.
You have to balance that
Yeah.
out, risk and benefit. And a lot of people, well, I think most people don't want to take medication. Nobody wants to.
Nobody wants to.
More
Yeah.
medication than what they absolutely need. But a lot of people sort of take that attitude or that opinion to an extreme, and they won't take a medication, even though they would be tremendously beneficial. I run into people all the time that have this thing called atrial fibrillation, which
AFib.
is AFib.
You heard that about a lot of, he's got AFib.
Yeah. And, a lot of people have that. And, when people, especially young, otherwise healthy people that are, in AFib, and they should be on a blood thinner, but they are not because they just don't want to take medication. That is really risky.
Yeah.
Very risky. It's like not treating high blood pressure, the two things that you
Yeah, and
just
that's the
mentioned.
other thing. And by the way, so much of this is, and one of the things that we talk about with Dr. Juliff all the time is, what are some of the things that can cause venous insufficiency? Bad diet? No. Hereditary? Yes. But all of a sudden, you start taking these medications and you say, I am in a management program now rather than being a victim.
Mm-hmm.
That's how I look at what's going on with me.
Sure. Yeah. It should be making you feel like you've got some control over your life. Yeah.
Yep.
So anyway, he had a DVT, didn't know about it, didn't have the typical symptoms apparently. But had he been diagnosed with a DVT, he would have been put on a blood thinner.
Anticoagulant. is what you're talking about.
Anticoagulation. And, typically, depending on the specific scenario, people are on a blood thinner for 3 to 6 months.
Mm-hmm.
Now, the blood thinner itself does not dissolve the clot. There are medications out there.
I was going to ask about that. Well, what does it do then?
Basically what it does is that it prevents the clot from getting bigger, extending, and also it, as that is happening, obviously that's also allowing for a little protection for it from breaking loose.
Mm-hmm.
So, we put people on blood thinner, and what happens? Well, the blood thinner is not allowing the blood clot to get bigger. It's stabilizing the clot. Then with time, like I said before, your body starts to, process that clot, and it'll break it down because there are molecules and proteins in our body that have that sort of effect. And so most of the time, again, at least some amount of reestablishment of blood flow through that clotted area occurs.
Well, one thing you said earlier, and I'm sure there's some of you out there were like me, when all of a sudden you find out that you might have to be taking this or that in forever. In other words, you're to a point in your life where this condition exists and it can be handled, but you must take this medicine. Mm-hmm. And missing those meds, making a mistake is not going to be good for you.
It can be risky.
Yeah.
So now, on the other hand, if we put somebody who's had a blood clot, if we put that patient on blood thinners, is everything going to go back to perfectly normal?
Yeah.
Well, unfortunately, no, it's not. Typically, there still exists some, residual kind of clot that we can see, especially if it's a big clot to begin with. So there's that problem. There's also the process that the valves, the one-way valves that are so important in all of our veins, especially in our legs, with a blood clot, often those valves become, dysfunctional.
I was going to ask you that. When we talk about these valves, and we've spent lots of times, and by the way, I need you to remind you to go to veinclinicsofhawaii.com and see some of the illustrations and some of the pictures there, because some of what we're talking about, we can't show you on the radio how bad they look. And once you just find out what causes that, like, when you talk about being on a treatment, if you've had a clot, Is it likely? Is this a one-time event, or once you have one, are you more likely to get them going down the road unless you get treatment,
Right.
or start maintaining it? Or something?
You are. Yeah. Anybody who has had one DVT, puts them in a little higher risk of developing another one at some point in the future.
Yeah.
Now, some people, in addition to that, have other circumstances that put them into even a higher level of risk, and that has to do with, genetically, genetic predisposition for the blood to clot, quicker than it should normally. So, and there's a pretty good number of people out there with those types of problems with their clotting system that makes them have a higher propensity to develop DVT.
Let's get back to our guy.
Yeah.
You say that you originally get him on this blood thinner for a couple 3 months or whatever it takes.
Yeah.
Why the time? Is that typically how long it takes for it to be effective?
Yeah.
Okay.
Got
to be patient.
I think it kind of goes back probably to studies that were done. Treating what's the optimal amount of time to treat somebody with anticoagulation after DVT, and I think that with time and study, et cetera, we've just found that as a standard amount of time, 3 months for a lower extremity DVT that has occurred for some reason, seems to be an optimal amount of time.
But this guy, you said, had no treatment.
He had no treatment.
That's interesting.
And that's probably why he developed, complete occlusion of that vein. So he didn't have the potential benefits of being treated with a blood thinner. And not only that, he didn't have the potential benefits of being treated like we treat somebody with DVT. For instance, compression. When somebody has a DVT, especially in the location that he had, getting over that DVT, the use of compression stockings is going to be beneficial.
Okay, I'm going to make an official announcement here. It was 41 minutes and 18 seconds before Doc mentioned compression. Okay. And let me tell you something. I am such a firm believer in this now. I'm wearing a pair of knee-high compression socks that have a puka for the toes. It's not a full sock. It's kind of a thing. But once you do this, not only do your legs feel better, they are smaller, and you're getting somewhere. And I think that once people grapple with that and get past it, there's people in your office that are, you look at them, they don't need to wear compression socks, but they all are, because they see the results of people that don't do this. Yeah. So this is a very key thing in part of in your ongoing maintenance and treatment, isn't it?
Well, I think that most people, benefit, or the way that their legs feel at the end of the day, especially if they work on their feet all day long. And hey, I'm in that category. I wear knee-high compression stockings every day that I work.
Thin as a rail, but he wears this, that goes to show you that it's like physician heal thyself, right? Prevent. But I think that what you're saying is right, because this guy, we got to get back to, him, but he is atypical of some of the things that he just wasn't able to do them anymore. Mm-hmm. And that gets very alarming. Yeah. People don't want to confront that.
Right, yeah. So we, he should have had compression. He should have been aware of elevation. He should have been aware of, follow-up and all that sort of stuff. And unfortunately, he just didn't have any of those benefits. So what do we do with him now? And that's the question. Well, with the left leg, it was pretty straightforward, because the left leg, he had a very standard kind of problem. He had superficial venous insufficiency, and we did endovenous ablation of the saphenous system veins that were refluxing. I think he had some varicose veins that we dealt with, And let
me tell you, gang, why that's so interesting, as Doc says it. But we're not talking about me here in this particular case study, but we could, because I have, exhibited a lot of these symptoms and had this treatment, including the ablation, which is something that, unfortunately, Doc, you have to explain this. I know we redefine this all the time. This takes such a long time to sneak up on people. Mm-hmm. Venous disease is not something you get over a weekend, because you something happened and now you got venous disease. This is a long time developing. So it's no wonder that sometimes it takes a while to get it cured or get it handled.
Well, yeah, and it takes a while also to recognize the problem. These symptoms come on, so slowly and over a long period of time that people get used to the symptoms. But the longer you wait, it's a progressive kind of problem. It doesn't get better with time. Doesn't get better if we eat different foods or whatever. So the longer it goes on.
But what happened with this guy is that took care of the left leg.
Yeah.
I mean, you went in there, did it was relatively standard, cookie cutter stuff that you do every day.
And he got better. Yeah. The swelling in the left leg got better. His symptoms went away, et cetera. So now, however, we're looking at the right leg and trying to figure out what should we do. And this is a little more complicated situation, again, because he's got a deep vein that's completely occluded. Most people have...
not working anymore.
Not working at all.
Yeah.
So what is going to be the best way to treat him, taking that into consideration? Well, sometimes we have to step back and we have to, use the first rule of medicine, do no harm. Because sometimes you can if you try to make things perfect, sometimes perfection is an enemy of good, and that was a definite potential for this particular patient. Now, he had 3 veins, like I mentioned before, that were refluxing: the great saphenous, the small saphenous on the back of the calf, and then this posterior accessory vein, which not everybody has. Sometimes people have them, but they're not refluxing. But he had a posterior accessory vein that was fairly large, and we did see some, flow going in both directions in that vein. Now, the standard approach, if it was a straightforward sort of thing, is that we would have ablated all 3 of those veins.
Yeah, ablated means bye-bye, right?
Yeah, we close the vein down.
Yeah.
And, we close the vein down, and that forces the body to reroute blood flow that would otherwise be going through those superficial veins. And so the question in this guy is, if we made his body reroute blood, where was it going to be rerouted to?
I was going to say, wait a minute. Yeah, where's it going to exactly? Yeah. That's a great question. I mean, great wonder. Yeah.
So the question in him was, we saw all of those what we called collateral veins that were, side roads getting blood around that clot. Now those collateral veins were deeper in, around the deep venous system. But in him, the question is, were some of his superficial veins also functioning as collateral blood flow? So was that posterior accessory vein possibly allowing for an alternate route of blood from the lower leg to get back up, even though the valves, that vein was big, valves were not functioning, and there was some to and fro flow. It wasn't all just up. There was some reflux, but if we close that accessory vein, is that going to be bad for the guy? That was the question. So we did the ultrasound, took a look at the report. I wanted to look at the patient's leg, myself with the ultrasound machine, and again, it seemed to me like even though there was some reflux happening in that vein was so large that I couldn't imagine that it wasn't, allowing for some blood flow, essentially as a collateral route, an alternate route of blood flow around the clot that was deeper in the thigh.
And by the way, this is where I think a real strict adherence to compression would be important, because what you're talking about, you thought there was at least some stuff going through it, isn't going to be greatly enhanced by having that compression. To know that if the valves are not working properly, at least the compression is helping to flow that blood upstream.
Right, right. Yeah, even compression on the posterior accessory, the collateral, flow. Compression in addition to just that vein being there, but compression on that vein is going to be of benefit in helping the blood go in the right direction. Anyways, it seemed to me that we need to move forward in a very cautious sort of fashion. So we did ablate or close down the small saphenous vein. That's the vein in the back of the calf, which was refluxing, and I felt like that may benefit him to at least eliminate the lower leg reflux. I thought that his that posterior accessory vein, as well as probably his great saphenous vein, were probably both too important with respect to maintaining collateral flow. We did not, do anything with those, and ultimately he did okay. He had some improvement in his swelling. Along with what we did and using compression on a real consistent basis, he's had significant improvement of his symptoms. He's had some gradual improvement in his skin changes, and so we felt like we did the guy a service. And again, it's it all goes back to. Sometimes you can't make something perfect.
Did he realize the danger that he was in?
I think that it was a surprise to him to know that he, because
it comes so slowly, right?
Yeah. Well, and also just the fact that he had this blood clot that was a complete surprise to him, and the fact that there were such substantial repercussions of that blood clot that he was having to deal with now, not only now, but, for the rest of his life. It was, I think that was a little surprising to him. But all in all, I think he's relatively happy with, finally getting things treated as much as he possibly could and getting back to a normal state as much as possible.
Okay. Now, before we run out of time, let's talk about, when you talked about, I read a piece about risk factors for developing PTS, and we got to make sure that bridge gets crossed. Okay, so I haven't had my DVT treated properly. What about this PTS? Now it looks like another storm's going on, or could.
Well, and that's basically what this guy had. He had post-thrombotic syndrome now, and that's something that happens after people suffer a blood clot, and especially if they're not treated fully. This guy wasn't treated at all. What are the risk factors if you have had a DVT? What are the risk factors of you developing this situation called post-thrombotic syndrome? And one of them is a very high DVT. So the higher up your leg and into the pelvis the blood clot is, the more the risk of developing these advanced changes in the leg with swelling and skin problems.
Yeah, it's a real trip to Las Vegas. It's a real roll of the dice. You don't want to be taking chances. Once you've been diagnosed, this one you really got to keep pursuing this.
Yeah. You need to be treated, and again, you need to be followed over a long period of time. If you had a prior DVT. If you had a DVT in one leg, it got treated. Now you have a second DVT. Well, the likelihood of you developing this post-thrombotic syndrome is a little higher in that category of people.
Once again, coming back to the same leg?
Yeah.
Same leg. Where it was.
Same leg.
Okay.
If you have pre-existing or developing venous insufficiency, obviously, that's going to put you into a little higher risk level for developing post-thrombotic syndrome. Increased body mass, in the obese, it's a little worse. And then also in older age groups, those people, and probably that has to do with activity level and that kind of thing. If they develop a DVT, then they're in a little higher risk of developing post-thrombotic syndrome, which is something that you don't want because it has, long-lasting repercussions.
Okay, had we been doing this program a decade ago, we wouldn't have been able to have as much, treatment going on, particularly with some of these blood thinners and other things. So if somebody did have a problem in the past, it's probably a pretty good idea now that they look into it again.
Yeah.
Get examined.
Sure.
An ultrasound and a trip to the office is a pretty painless thing.
Yeah, that's pretty easy. That's pretty easy, and we can assess very quickly not only the function of the deep vein, but your superficial venous system, and do whatever we need to optimize your situation.
Okay, so what we want you to do is go to veinclinicsofhawaii.com and check it out, and learn a little bit more about this, and make an appointment, get an examination, and start yourself on the right path of recovery and being able to have a more active lifestyle. That's what everybody wants. Thanks very much for listening. We'll see you again next time. Remember, it's Vein Clinics of Hawaii at veinclinicsofhawaii.com. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.